Good morning, everyone. Welcome. This is Bill with iPass. Just letting you know we're waiting a moment or two before we start to work out a small technical detail. So please hang on and we'll get started in a few moments. And allow us to talk among ourselves for just a second. Marta, do you want to test your mic?
Bill, thank you. I don't know what was happening. I was in the panel and the screen, it didn't even allow me to close the screen and start again. So I have to restart the whole computer.
Okay.
But
well, looks like
now it's okay, right? The voice and
perfect. Yes.
Perfect. Do I keep the video on or I turn it off until I speak?
I think until you speak, that's okay.
Okay.
And then we'd agreed that while you were offline, that when we came back on at the end for questions, we would all come back together with our videos on.
Great, perfect, thank you.
Okay. Good morning, good afternoon, good evening to everyone. Welcome to this session. We're so glad that all of you could join us. And thanks for joining for what I know you're going to find to be a very fascinating set of presentations, all focused on safe abortion. I'm Bill Powell, a senior medical scientist with iPass, and will be the moderator for this session. And on behalf of iPass, we are delighted to be hosting this webinar in partnership with the IWAG Safe Abortion Care Sub-Working Group. Before we dig in, I imagine there'll be some folks joining us as we go along, but just wanted to mention a couple of logistics. I believe you'll all be joining in a muted mode. We will take questions in the chat box or the question box throughout the webinar. So feel free to enter your questions in one of those formats, but we'll wait till the end actually to answer those questions. I think that's basically it for logistics. We hope you can hear us well. We've tested and practiced, so we hope this will come off well for everyone's participation. So we know that safe abortion care saves maternal lives, it prevents maternal morbidities, and is a crucial intervention to manage the consequences of sexual violence in emergencies. Yet despite many factors that place vulnerable women and girls at increased risk of unintended and unwanted pregnancy, refugees and internally displaced people are systematically denied access to safe abortion care, even when it is legally allowed. And we know there are a variety of reasons and myths for this, and some of which include deprioritizing safe abortion care and service delivery, incorrect assumptions about women's beliefs, and misunderstandings of the law. So this panel will address these issues with research findings of MISP implementation gaps and challenges in Colombia, community perceptions around safe abortion in South Sudan, and innovative use of legal risk as a lens to assess the legal context for abortion care. Next slide, please. Again, we have a great panel that we'll be going through here. Marta Arroyo from Pro Familia in Colombia, Guma Patrick Issa from the IMC in South Sudan, and Patty Schuster from iPass will be your panelists today. And let's move right into the first presentation, and let me introduce Marta. Marta Arroyo is an executive director, the executive director of Pro Familia. Welcome, Marta. In Colombia. It's the longest standing non-governmental organization that protects and advocates for sexual and reproductive rights, specifically those of women and youth. Leading an organization like Pro Familia has given Ms. Royo the opportunity to help achieve significant political and social transformation aimed at improving the status of girls and women in Colombia, targeting marginalized areas where women and girls experience vast inequalities, which is seen in high teen pregnancy rates, gender-based violence, low levels of reproductive autonomy among women, including those of migrants and unsafe abortion. She's a social economist with more than 15 years working in the health sector. Welcome, Marta, and take it away.
Thank you, Bill. Good morning, good afternoon to everyone, and thank you so much to IPAS and EWAC for allowing us to share with all of you this work that we do here in Colombia, regarding especially all that has had to do with the Venezuelan crisis. What I'm going to share with you is, on one hand, the results of a research that we carry out regarding the migrant crisis here in Colombia, and a few of the advocacy actions that we have carried out regarding making sure the provision of abortion services, which are legal in here in Colombia, are done in a proper way. Next, please. The next slide, please. Can you see the next one, or should I? Because I know it by heart.
Casey, is it having trouble advancing? Or?
You still seeing the first one, the first slide, or does anyone see the next one?
No, we're still on the first in my screen.
You see, this is why we cannot go 100% digital.
So folks know we had a practice session and this worked flawlessly last week. So
yes.
I think it was a moment to work this out. Yeah. Casey, can you let us know what seems to be going on? Sorry, folks. Just hang on to this for a moment. Sorry, folks, working behind the scenes here. Please bear with us and appreciate your patience and a nice comment in the box there. Keep hanging with us for a few moments. And Marta, thank you for
I'm here.
patience.
Don't worry.
Yeah.
Don't worry. Mm.
Sorry again, everyone. We seem to have lost contact with our logistics person. And so we're trying to figure out what's going on and see what kind of problems she's having.
Should I try? Can I share my screen? I don't want to touch anything.
I don't know. That's a very
Um,
good question. You should be able to, because you have the same privileges as a presenter as everyone.
Let me see.
Okay.
I'll do it. If anything happens, then I'll connect again.
Well, it can't be. We're just sitting here waiting, so that'd be great.
Okay, let's try and see.
Yeah.
If yeah, I can share it, but it doesn't let me move it. It's not going anywhere.
Okay.
Ah.
Well, Marta, you could
Yes.
pull up your presentation on your own computer.
Yeah, that's what I try to do. I have it here.
Okay.
And I put, you see the little icon that it says share the screen, and it shows.
Okay, it looks like we're
okay, you're
making
back.
some progress.
Yes.
Thanks for your patience, everyone.
It's asking me permission to record my screen of this computer.
Yes, go ahead.
Yeah.
Sorry, folks. There are lots of emails and chat messages flying behind the scenes, folks. We're really trying to work this out. So apologies, our logistics person lost her internet. I'm just trying to get back. And she's coming back, it sounds like. So one more couple of minutes, we'll get this worked out. Apologies and appreciate your flexibility.
Oh, I see my presentation.
Great.
Okay, is that the right slide?
Yes.
Number 2.
Yes.
Okay, and Casey, are we ready to go then from your side? Oh, let's try it and see.
Well, you tell me if I have to stop or, well, we see how that goes. You tell me when to start.
Go ahead.
Okay, great. So I'm going to share with you a little bit of what we do. As Bill told you, we are a private NGO. We have been working in Colombia for 55 years now. And in a year, we provide around 3 million services to 700 people, of which 82% are women and around 42% are young people below the age of 24 years old. In Colombia, abortion is legal under 3 causes. There is no gestational limit. We provide the services in our clinics. We have around 40 clinics by now in Colombia. And we have special programs that help us subsidize the services to the Venezuelan migrants so they can access the services in our clinics, including abortion, for free. Next slide, please. So it was not, even though the humanitarian crisis started here in Colombia long before the year 2016, it was not until this year that the government actually pronounced that that we were facing a humanitarian crisis in Colombia. And it was that pronunciation from the government that allowed a lot of the mechanisms, support mechanisms like the UN and all the different agencies that work with it, to start providing a more comprehensive attention programs to the crisis. And it is under this new context, after the year 2016, that we decided to carry out a research trying to find out what the unmet needs of the migrant population were specifically regarding sexual reproductive rights. And we carry out this research in 4 cities of Colombia: Arauca, Cúcuta, Riohacha, and Valledupar. And the reason we chose these cities was because 3 of them are some of the main crossing points between Venezuela and Colombia. We share a border of more than 2,000 kilometers. So there are some specific crossing points, but most of the crossing points are irregular and they land in these cities. Next, please. So just to keep, wait. The next slide. Yes. So just to give you an idea of the general context, what this Venezuelan crisis has meant to Colombia, they calculate migration, the Migration Institute in Colombia calculates that by the year 2021, we will be having around 4 million Venezuelans here living in Colombia, regular and irregular. Nearly 1.5 million Venezuelan migrants are currently living in Colombia. And because of the COVID, we started seeing news saying that some of them were trying to return to Venezuela. But since the borders were closed, a lot of them have been trapped for the past 6 months. Migrants often encounter all types of difficulties trying to gain access to sexual and reproductive services. And some of the problems have to do, of course, with their irregular status, but also with the fact that they lack absolutely any type of economic resource in order to pay for them. And they have very little knowledge of the places like Profamilia where they can have access to the services for free. During the year 2016, in the case of Profamilia, 3 out of 4 abortions were provided to Venezuelan women. Next, please. So with the support of EWAC, we carry out this research, and the purpose is to evaluate the implementation of the minimum initial service package, the MISP. You know that this is a very robust document that not only specifies the needs that should be provided by the government for the different agencies, but also it carries out an operationalization guide in order to do it. So all the documents by the EWAC were translated into Spanish because they were going to be carried out with people that have no knowledge of English. And this toolkit enabled us to collect information from different sources in order to build an overall overview of the sexual reproductive needs of the population, the services and the barriers, including safe abortion care. You can see very briefly that we evaluated 21 healthcare facilities that were supposed to be providing the services. We interviewed 23 key responders, I mean, people the decision makers. We conducted 24 focus groups, including men. Men are a very important part of this equation, and from different age groups, so we could have a very good overall idea of their needs. Next slide, please. Next. Great. So some of the main results and findings. The most urgent needs of the Venezuelan migrant population in these 4 cities are definitely access to contraception methods, abortion and post-abortion care, but also we saw a lot of needs regarding the prevention and attention of sexual and gender-based violence. Most of the women who participated in the focus groups were not aware at all that abortion was decriminalized, is decriminalized in Colombia, and that a lot of several health facilities are in the obligation to provide the services for migrants also. Many of the participants in the focus groups had a very negative perception about abortion, and of course about the women who had already undergone abortion services. And they mentioned an infinite amount of places and people and cases under which some of them had to go for an very unsafe abortion services. At the general level, we have to say it, there is a lack of knowledge about the MISP. Very few health organizations and health providers know that there is this toolkit that can really help them provide the services. And of course, I would say that not only abortion is really unknown, but also everything that has to do with HIV and gender-based violence programs. One of the main results also had to do with the interagency coordination addressing migrants' needs, specifically sexual reproductive, was absolutely lacking. So we have been working very hard in order to strengthen that it is the message that it's absolutely imperative to coordinate the response, not with the health system in general, but also with the sexual reproductive services, including HIV and abortion. Migrants are still facing, after so many years of dealing with a migratory crisis of enormous proportionality, they're still facing too many barriers accessing their rights. And the healthcare facilities, we have to realize that, you know, Colombia is quite developed, but at the same time, the healthcare facilities, their infrastructure is very, very poor. And not only regarding in terms of the physical buildings, but also regarding the professionals that take care of it. So sexual reproductive rights are never a priority of these places. Next, please. Next. We lost it again. Bill?
Yes.
Do you see, are we still on the same slide?
Yes, we are. Casey doesn't have sounds. We're trying to read your lips and indicate to her through text messaging when it's time to change. So again, working through a variety of methods here. One of my colleagues, I think, is messaging her to to advance the slide.
Yeah.
Sorry.
No, in the meantime, I have to share with you that, as health providers, we know that, and we have already implemented in all around the country, telemedicine and free counseling. But these are, imagine is we that we all have all that is needed, the computers, our mobiles, and good connectivity. Imagine what it is like to people that live in rural areas and for migrant population. So we know that self-abortion care, and we know that the digital tools and digital connectivity has helped us make amazing progress regarding the provision of health services. When in a country like Colombia, where you have 70% of people living in the rural areas, that has not been a reality. And I have participated in a lot of meetings and webinars where the focus has been self-abortion care. We have to make sure that we provide it, and at the same time insisting the reality of what many of our countries face regarding connectivity. We understand that it will be the best solution for many women, but at the same time, look what happens with connectivity. This is the reality, and it's hard to find the perfect solution. But I think we have started including in our advocacy actions, advocating for making sure that at least every single town in the country has one place where people can go and access and have connectivity in order to be able to access the health providers and services.
Yeah.
But yeah, it's a huge challenge.
Okay, Marta, I think if you, I know you're probably on your conclusion slide. And
well,
our
I'll go
colleague
ahead
tells us that she's there. It just is not advancing in the online platform. So maybe you can go ahead and talk, and we'll try to catch up.
Great.
Yep.
And you'll tell me, so I keep moving. Thank you. Some of the main conclusions of the research: it is critical to increase and promote the interinstitutional and interagency coordination addressing migrant sexual reproductive care. The MISP, we need to carry out more advocacy and more communication strategies so that it is better known in the countries where we're all working with it. We have to share the common objectives with humanitarian responses, teams and organizations. Sexual and reproductive rights have to be included in the response. And of course, improve the availability and access to these services, eliminating the barriers, especially when you have to do with abortion services, and especially when you have a country where it is legal to provide it. We have to have a specific focus on girls and young women, because they are suffering not only lack of access and a lot of barriers, but also a lot of gender-based violence, and they're totally unprotected when crossing the borders. And we have to have, of course, better communication strategies. The next, please. Well, if you see it, it's so you wanted to share with you very quickly some of the advocacy and capacity building actions that we have carried out in the past years, thanks to the research and the evidence that was provided by it. A lot of events and meetings with local authorities. We need to train local doctors. That has also to be included in our programs and projects, because they need to know the women's rights to sexual and reproductive services. We have developed certified workshops with healthcare providers, so that, and the protection authorities also, because in many cases, when it comes to migratory crisis, the protection authorities are the entry points through which we can share information. Active participation in the interagency and interinstitutional spaces with the National Health Cluster here in Colombia, making sure sexual and reproductive rights are there, and abortion services, and of course involvement of the social society. Just to finish, some of the main recommendations to increase the provision of safe abortion services within the humanitarian response here in Colombia. Again, training doctors and all the agencies that are working, trying to help in this migratory crisis. We have to develop a system of referral in those cases that we cannot attend. Where can we send the women so they do not end up carrying out a very unsafe abortion? We have to design mechanisms to facilitate the health workers so they can have access and management of the drugs such as mifepristone and misoprostol in order to be able to provide first trimester abortion, safe abortion services. Promotion advocacy. Advocacy has to be permanent at the local governments, but also at the national level. And we have to strengthen post-abortion contraception. Most of the programs responding to the crisis has a very strong focus on prenatal and maternal care, but we have to remember that these women need to have access to contraceptive programs right after they deliver a baby, so they do not end up facing an unwanted pregnancy again. The minimum initial service packages, the MISP, should definitely consider access to early abortion medical service, a lot of focus on first trimester abortion services, alliances like the one that we have with EWAC is an amazing space to carry out the advocacy actions, because we demonstrate that overall in the rest of the countries, abortion cares are a priority in the response. And the digital tools I already explained to you, they are amazing. They have helped us, I mean, been a great support now under the COVID, but we have to remember that for many women and for girls, it is very hard. They do not have connectivity. They do not have mobiles, and when they have it, they don't have plans that allows them to talk through a WhatsApp. So the physical presence of healthcare providers is critical in order to make sure that they are not left behind. So thank you so much. Sorry for the inconveniences, but thanks a lot for being able to share all of this with you.
Thank you, Marta. That was a wonderful presentation. And again, I apologize for all of our background technical trouble here. There were some great slides that hopefully we'll be able to see before we lose the connectivity today. But fascinating work on this very important topic. And we really appreciate you sharing that with us. And I'm sure there'll be some questions from the team, from the participants we'll want to address. Let me pause for 1 second to catch up on the text messaging here and see where we are in terms of our next presentation and where we can advance the slides or not. Just 1 second. And again, apologies for this to everyone. Hold on a minute or two more, folks, while we organize a little bit. Again, appreciate your patience here. Okay, everyone, let me introduce our next speaker. And again, apologies for that. I hope you're all able to see the slides now. Guma Patrick Issa is a meal coordinator with over 6 years experience working with International Medical Corps in South Sudan. As a meal coordinator, Guma specializes in monitoring, evaluation, accountability, and learning, and is responsible for coordinating research work. He recently participated in operational research entitled Building the Body of Evidence in Clinical Capacity Development for SHR in South Sudan. That was in 2016. Guma is a powerful workforce in the workplace and uses his positive attitudes and tireless energy to encourage others to work hard and succeed. Again, Guma will be presenting on perceptions from the community about induced abortion in South Sudan. And we almost had that slide set up, and then it just disappeared. So Guma Patrick, let me turn it over to you, and we should have that back up in just a second if you'd like to take over the presenter. Thank you. Welcome.
Thank you, Bill. Hello, everyone. I'm going to present research that IMC conducted in 2018 in collaboration with the RAISE initiative at Colombia University. And the study used a mixed method to identify the factors that influence access to, use, and provision of post-abortion care in Juba POCs 1 and POC 3. So this presentation focuses specifically on the community perception of how the civil war has contributed to changing perceptions, attitude on unintended pregnancies and induced abortion. Next slide. South Sudan gained independence in 2011, and in 2013, political tensions led to fighting. This fighting led to forced displacement of about 4 million people, of which 2.5 million people took refuge to the neighboring countries, and an estimated 2,000 people fled to UN protection of civilian sites across the country. These conditions in the POCs are very poor, and they were meant to be like for short time. This conflict has further normalized the gender inequality, with women and girls experiencing other forms of violence as coping strategies, such as early and forced marriage and transactional sex. Improvements in health, and more specifically on sexual reproductive health, have been relatively slow to take hold in South Sudan. In addition to high maternal mortality, South Sudan also has a very low contraceptive prevalence rate of about 4%. Next slide. Next slide. All right, International Medical Corps started working in South Sudan since 1994 and has worked to deliver healthcare services and training through integrated interventions and strengthen the capacity of public health system in South Sudan. IMC has currently active sites in Malakal, Wau, and Juba POC, where we support about 23 health facilities in providing primary health care, including comprehensive sexual reproductive health services, and conduct programming to improve health, nutrition, protection, and GBV. We work with government of South Sudan to improve primary health care, including post-abortion care, the protection of civilian sites in Juba. Next. Yeah, like I said before, this component of a larger study is to identify the factors that influence access to and use of post-abortion care services in the 2 POCs in Juba. The refugee camps in the Maban. And this presentation will focus only from the 4 focus group discussion that we conducted with the 36 male and female community members living in Juba POC to explore their perception of abortion, women who induce abortion, and their use of PAC services. The discussions were led by trained female and male facilitators in web, and these discussions were recorded and transcribed and translated into English for further analysis. To protect confidentiality, all the discussions were held in a private space and verbal informal consent was obtained from all the participants. Next slide. Yeah, although initial discussions and reactions to induce abortion and women who had them were generally negative in the focus group discussions, participants in all the group discussed that unintended pregnancy and induced abortion appear to increase during the current conflict. Participants attributed this increase to changes in the policy situation due to the war. Men often mention unintended pregnancy was handled in one way before the war and another way now, while women refer to more to instability and additional difficulties women face now. Discussions of how the war has changed the perception of abortion to become more pragmatic are grouped into themes: the instability and related poverty, transactional sex, changing marital practices, and rape. Next slide. Participants refer to concerns about the instability of their current living condition, including the lack of access to food for women and her children, as reasons why women or couple may choose to have an abortion. Participants refer to the frequent separation of families in the POCs, where women and children are left in the camps and their husbands are somewhere either fighting or attending to their other field work. So the husbands are away or fighting and families are generally separated. So this is basically the instability and poverty the women were referring to. Next slide. Yeah, because of this poverty and instability, participants reported increase in transactional sex in the POCs. As mentioned, many men were away fighting or doing other field work somewhere, while their wives and children live in the POCs with little support. Therefore, a woman may resort to selling sex to gain support for herself and the children. If she becomes pregnant, she will terminate the pregnancy out of fear her husband will find it out or maintain a transactional relationship. Participants in all groups highlighted that unmarried girls who were separated from their families due to the conflict were particularly vulnerable. These girls engage in sex with older men or peers, often for money or food, so they could survive. If the girls became pregnant, they will terminate the pregnancy on the assumption that men could not or will not support them and their child. Several participants referred to men who had sex with multiple adolescent girls because they had money. Women in the older age group blamed these men who had sex with multiple girls and then sent them off, terminate the resulting pregnancy, without caring if these girls are really going to die or not. Next slide. Participants also described that the traditional practices of bride price, where the man pays a dowry to a woman's family, may encourage girls to have an abortion in the POCs. They describe this as a change from the way unmarried girls' unintended pregnancy used to be handled. Previously, the families of the boy and the girl would negotiate an appropriate dowry and marriage would be arranged. However, the poverty of many in the POCs made appropriate dowry difficult for men to provide. Participants described that if an married girl became pregnant in the POC, her family may decide together that she would have an abortion if the partner could not provide a sufficient dowry, or if the partner decided that the parents decided that the partner was unsuitable for her for some reason. Given the difficult economic situation for most of the families in the POC, participants suggested that girls may feel pressure to bring resources to their family through marriage. If she gets pregnant and the man lacks cattle for the dowry, she may terminate the pregnancy because her family, she's fearing that her family may find it out. Participants also in several groups mentioned that girls may choose to do this in part out of fear that the partner or herself will be killed by their family members. Next slide. Participants in all the groups mentioned that women in the POCs terminate pregnancy due to rape. They said that women experience sexual assault perpetrated by the security forces in or near the POC camps. Women also find it risky of rape. So they usually, when they leave POC to go out, they end up being raped. So when they are raped, they will terminate the pregnancy to keep the rape secret from her husband or the family out of the fear she may be rejected. Young girls in particular will find their future marriage perspective ruined if people knew that she has been raped. Participants specifically referred to rape by men from opposing ethnic, in this case, in this POC, particularly the men from Dinga tribe, which was viewed as even worse for the women than raped by someone from their community. Next slide. Yeah, the findings reveal several instances where a shift in attitudes and behavior as a result of increased vulnerability of women and girls can be seen. Participants recognize that the abortion was more justifiable or perhaps necessary given the confluence of the current situation in the POCs due to the war. The consequences of extramarital pregnancy for married or unmarried women were perceived to be severe and suggested that abortion was now an acceptable option. Participants, especially men, referred to how things were done before the war compared to now, suggesting that the conflict contributed to some changing perception and attitudes towards abortion. The changing attitude towards abortion here may be a pragmatic decision made in the face of the intense poverty and lack of economic opportunity, separation of families, increased transactional sex, disrupted marital norms, increased sexual violence, and low contraceptive use. Next. Little evidence is available about abortion in South Sudan, especially there is no known result about what is happening in the population in the POC. This research is one of the first studies to investigate the impact of the current conflict in the community perception and practices related to unintended pregnancy and induced abortion among the IDPs. Despite beliefs that the abortion and contraceptives are taboo topics in South Sudan, the increasing unused discussions of abortion as they progress provided an opening to encourage dialogue around abortion and reduce abortion-related stigma. Our findings suggest an increased recognition for the need for contraception to reduce unintended pregnancy. They also highlighted the need for increased protection measures and investments in women and girls to improve gender equity and reduce extreme power imbalance faced by women and girls in this society. The impact of war and forced displacement can have a devastating effect on the lives of women and girls. However, addressing this stigma related to abortion and contraception can significantly contribute to reduce maternal mortality. Thank you. That's the end of my presentation.
Thank you, Patrick. That's fascinating work in a challenging place, and we appreciate you sharing that important work with us. And let me remind participants that, as you think of questions for the presenters, feel free to go ahead and put them in the question box or the chat box, and we will return to those and make sure that we're not missing any as we go along at the end of the presentation. And luckily, we have a little extra time. Given that we had an hour and a half scheduled, but only 3 presenters. So please add your questions there as you think of them. Okay, let's move on to our next presenter. I'm sorry, I'll put my face back up there so you can see me talking. Let me welcome my colleague, Patty Schuster. Patty researches the regulation of abortion globally. She's a senior legal advisor at IPAS with her current focus including U.S. foreign policy on abortion, self-managed abortion in the law, and legal epidemiology. She's also a fellow at the Center for Public Health Law Research and teaching faculty in the University of Pennsylvania MPH program. And Patty's going to talk to us about legal risk in crisis settings. Over to you, Patty.
Great. Thanks so much, Bill. And hi, everyone, from my home office to your home office or living room, kitchen, garden, maybe, wherever you're sitting in these strange times. Thanks to Bill and Tam and my IPAS colleagues, and especially to Marta and Patrick for giving such rich presentations, and to IWAG for bringing us all together to share some information with you. So today I'm presenting on an approach to addressing abortion law that we've developed here at IPAS, and that's managing legal risk. It's an approach that we developed for addressing legal issues in all types of settings. And now with the Center for Reproductive Rights, we're working on a tool for using this approach in crisis settings. I'm going to do something slightly different with my presentation. The tool right now is in draft form. We're still developing it. And what I wanted to do is use some of our time together to collect feedback from the audience on the draft. So if everything works well, we'll end this session with some ideas for improvement. Next slide. So this approach is to address a specific problem that we've seen faced by NGOs and agencies who are wishing to support access to abortion services. Setting up abortion services in a clinical setting, as is pictured here, but also NGOs and others who want to provide information and pills for self-managed abortion or want to set up telemedicine. And the problem is that abortion is different from other healthcare services. Abortion in most countries in the world, even if it is legal, has criminal regulation, the criminal law regulates it. And so a lot of times the abortion law is a question that people ask. However, abortion is also highly stigmatized, and abortion services are also often blocked by various gatekeepers, whether they be donors or government officials or staff of NGOs or UN agencies. And in this context of stigma, abortion legality can become a proxy for abortion discomfort. And what I mean is that people who are uncomfortable with abortion can sometimes point to the law as a reason not to support abortion access. And so what this tool hopefully will do is kind of interrogate that a little bit to help understand it more. Next slide. What we're proposing, instead of assessing the law, is recommending approach to manage legal risk. And here's what the legal risk approach does. It encourages folks, maybe their staff of NGOs that are considering offering abortion, to look at the question of legal risk, whether that rather than the question of legality, to move from assessing legality of abortion, is it legal or not, but managing the risk that might be associated with it. And let me explain why that's important. Next slide. What is legal risk, or what am I talking about when I say legal risk? It's basically legal events that can arise when providing abortion services. Legal consequences can take place, and what I want to emphasize here, it can take place in any context. Bribery, harassment, arrest, prosecution, imprisonment. These are things that IPAS have seen happen in places where abortion is legal. For example, IPAS Ghana had dealt with an arrest of a midwife who was providing abortion services according to standards and guidelines under the law, but yet was arrested because the police were unaware of whether or not abortion was legal. So legal risk is something that can be present in any context. Next slide. And kind of the flip side of that is we may see no legal risk even in places where abortion is highly restricted. So there's certainly a relationship between whether abortion is legal, or the legality of abortion, the restrictions of abortion, and whether legal risk is involved, but it's not a direct relationship, and there are other questions we might need to consider when we're looking at working in a particular context. Next slide. So what I'm going to do next is share this draft tool, which we've adapted from an IPAS internal tool, and now are working with the Center for Reproductive Rights on finishing it so that we can share it. But I really am sort of taking advantage of I see 60 people online joining us to see actually how useful it is and what ideas you might have for improvement. Next slide. So the next slide is just a preview. Don't answer these questions yet, or you can, but what I'm going to ask at the end of my presentation is for you to answer these questions in the chat box. And so I'm putting these up now for you to consider as I'm presenting the tool itself. What's useful? What's particularly useful about the approach? B, what's not useful? Maybe there's certain pieces that aren't. And lastly, we'd like to hear from you about who might use this tool and in what context. So, so I really appreciate you giving your thoughts on this tool, and hopefully we'll find it useful. Next slide. Now to present it. The tool has 5 parts. There are first 2 parts in blue we won't talk about too much here, and those are around human rights obligations underpinning access to abortion, and then what is legal risk. Some more in-depth discussion of my previous slide. What I'm going to go into a little more in depth, just a little, is the orange sections around managing legal risk. And what I'll present is our approach to managing legal risk, which is basically a 3-step process. Understanding the context in which you're operating, assessing the risk, given what the context is, what is the risk? And I'll go into that, and then making plans to reduce risk if indeed it's something that needs to happen. Next slide. So this is a preview of the first section of managing legal risk, and that's around understanding your context. And so you'll see that the first questions are questions you ask, and then there's a section to put the answer to the questions in as the user is going through the tool. And if the questions are unknown, a suggested approach for finding the answers to the questions. So you'll see the very first questions are about the law. Which abortion laws apply? Are the planned activities permitted by law? However, law, of course, is not the only piece of information relevant to legal risk. Next slide. So I've condensed some of the different types of questions that the tool asks users to consider. For example, well, I talked about the law, but also reporting requirements around abortion, knowledge of the law among healthcare providers, but also staff of UN agencies, security officials who might be in the area. Have there been arrests or prosecutions for abortion? And some of the suggested approaches for seeing if there are arrests or prosecutions are around looking at the media, maybe doing some research to find out whether people are aware of them. Is there support for abortion from communities and agencies working in the area? And does the agency or donor have working in the context have any guidelines on abortion? So the overall in step one, it's really what are some pieces of information that will help understand the context in which you're working, in which the user of the tool is working to know about legal risk. Next slide. And what we do in the second section, and I'm going to ask you to disregard the second. It's a repeat, the second row here, but it's to focus on the first row. The tool asks users to consider the types of events that might take place, the types of legal events that might take place, and assess their likelihood of happening, and then also the impact of programming. And so it's a kind of modified risk matrix to assess the risk that would incur from working on any activity. So hopefully the first section, the context will inform whether there's bribery or harassment. Is that likely to happen or not? And so there's a ranking system 1 through 3 on the likelihood, and you can see on the impact of programming. So this is what the particular chart looks like for the actual workbook kind of tool. Next slide. And then on the next slide, basically it's a summary of what's there. So users of the tool are asked to consider arrest, prosecution, bribery, harassment of different groups of people who get abortion, community partners, health providers, community members. Has this happened? Is it likely, and will it have an impact on programming? So once the user is done with step 2, we go to step 3. Next slide. And for people who have, or for people using the tool, users of the tool who have found that the legal event has a high likelihood of happening and also has a big impact on the program, what we do is we detail some steps or some plans that organizations, agencies can make to reduce legal risk. Some of these are from IPAS staff experience, and then also from working with partners. Some of the activities or programs that can be implemented in order to reduce legal risk associated with abortion. Partnering with lawyers, training and sensitizing the legal profession, or in crisis context, military authorities, partnering with community groups. And then also I wanted to share some work that was done in IPAS Ghana, IPAS Bolivia, also IPAS Nigeria, who have partnered with police actually to enlist the support of police to understand abortion and to enable access to care. So those are the first 4 of 9 suggestions. Next slide. Here are some more. Providers who might be arrested might need support. So that's something that organizations could actually budget for. Training healthcare providers on privacy and confidentiality. The institution that the user of the tool is working with might have a risk mitigation strategy. And then also establishing a referral system, self-managed abortion or telemedicine instead of providing abortion in a facility also might be a way to reduce legal risk. And so these are all, these are 9 suggestions pulled from our experience as an organization and partners, and they're to consider, certainly depending on the context. I know Patrick talked about sexual violence and security, security agencies. So depending on the context, depending on the players and the gatekeepers, some or more of these may or may not work. So it's suggestions to consider. So now is the experimental part of my presentation, next slide, where I'm going to ask you for feedback. I have 3 questions to ask for feedback. And what I want you to do, I'm asking, as a presenter, I can see the chat box. So I encourage everyone to put questions in the chat box and make sure that the drop down is sending the questions to organizers and panelists, or excuse me, your feedback, not questions. I welcome questions as too, but if you have some feedback that you can give on the tool to help us improve it. And this is the first question. What is most useful or interesting about the overall approach, about shifting to from looking at the legality of abortion to looking at legal risk? And so you can go ahead and put things in the chat box if you have feedback. And as I said before, we'll also have an opportunity for you to share more written feedback online through a survey. And also what we're wondering is if the format of the tool, the overall format, is useful as sort of a worksheet that that folks, that staff or whomever can fill out. And I'm going to pause here, and I'm not seeing any feedback. So Tam, if you can see some that I'm not able to see, you let me know. And all right, you can still answer this question, but we'll move over to the next in my present webinar experiment. We'll see if this works. Okay, next slide. If anyone has feedback in the chat box. Next slide, please. To ask, and the next question that is not appearing, oh, there it is what is not useful about the tool? Is there anything, is anything missing? So I'm seeing a little bit. I really like how you equate, so thank you for that. Fortunately, I don't see who this is. So whoever you are out there, thank you for that feedback. That discomfort abortion is kind of correlated with the excuse to consider abortion legality. So legality of abortion really does become an excuse. And what we've seen too is that, you know, abortion laws are certainly interpreted all different ways all around the world. And so it's really very hard for folks not working on abortion to read the law and have an opinion and be able to know whether or not there might be risks that are taken just by reading the law. Next slide. What I'm going to do, I'm going to shift gears a little bit, given my experiment is not meriting a ton of feedback. The other thing that we're interested in knowing, next slide please, is how the tool might be used. For example, how would it be used? So some of the things that we're considering is this like a PDF that people can print out and take to a meeting and fill it out, or is it something that that should be done online, that maybe one individual or 2 individuals will do online? So these are the kinds of questions that and interests that the kind of feedback that we're interested in as we're moving forward with the tool, and certainly the inability to travel makes it harder to test in person. And I'm going to ask Tam to put in the chat box to send to everybody. It's a link to a Google form and or a Google survey that asks some more questions and has some screenshots of the tool as we're collecting feedback, and we'd be super grateful. And then I see questions that let's see, I see a question here that not working abortion is related most to organizational risk. Any options that might help us cement relationship with government? So I know that that when IPAS has some tools around values clarification, that we have indeed worked with government officials to help ensure more comfort with abortion. And I think part of it is really understanding where the discomfort is coming from. A lot of times it's not articulated, but it's sometimes placed on another person. So voice those of concerns around organizational risk, if you start to try to understand where that's coming from, it's actually personal discomfort. So personal discomfort manifests in a whole lot of different ways. So values clarification, I see cemental relationships with governments can be very helpful for that. I see a clickable PDF for clicking on links would be helpful. And then assessing the court system. So that's an excellent addition as well that I'm seeing here. I think somebody else had a suggestion to look at litigation strategies, perhaps a test case to see if there is a prosecution. So depending on the context, yes, that's a great example, and we can add that as well as a suggestion of strategies. Could be testing the court system and seeing if it's amenable, or even doing some judicial trainings in advance of trying to develop some judicial decisions on abortion as well. So I am grateful for all of that feedback, and I hope that we'll get some more online too. So Tam, there should be a link in the chat box from Tam on a tool to get more questions. So I'm to ask you more questions for further feedback on the tool. So I'll stop here and appreciate those thoughts and feedback. And it's our hope that we want to produce something that's useful and not something that's kind of sitting online. And then I have my email up there as well. Thanks very much.
Thank you, Patty, and others, everyone that's been putting some things in the question and chat box. Fascinating approach, and I think we can't wait to see sort of how this, where this takes us in the future, and look for some ideas to do that or partners to try that out. If I could ask all the panelists to come back on with their video. We have a few minutes, and we'll see what kind of questions or discussion comes from the team or from the participants. We do have one question, Marta, that's in the question box. We'll start with that one for you. And it's, can you say more about the xenophobia you mentioned and how it impacts care? And
Yes.
before you start, let me just add one for Patrick that he can be thinking about before starting while you're speaking, and that's, you mentioned one quote that abortion was handled one way before the war and another way now. And I just wondered if you had more information from the person on that, if you could expand on what those different ways were. Tell us more about what that participant was thinking. Let's start with those two, and then if you have, again, questions for any of the participants, please put them in the question box. Thanks.
Well, thank you. Yes, what has happened is that Colombia for many years have some particular conditions that had make very complex, especially in rural areas and little towns, and that has had to do with the guerrilla movement and the drug trafficking business. So many of these places where the Venezuelans are arriving in Colombia are already little cities and towns that had suffered extreme violent and poverty conditions. So by arriving and then suddenly seeing all these UN agencies and other organizations helping them and subsidizing the services, that has created also an inequality environment for them, creating and exacerbating the xenophobic reactions to the Venezuelans. And suddenly, everything bad that happens, they have started blaming the Venezuelans. Right now, the past week, we have several marches going on in several cities. And what you see in the news is that, oh, there was a group of Venezuelans throwing rocks at the police system. There was a group of Venezuelans robbing a bank. And now all the blame of everything bad that is happening is being blamed on the Venezuelan migrants. So that has really created a xenophobic environment that in many cases, even for us, that I mean, the population knows very well. We have been working in most of these cities for 55 years now. But in our cases, sometimes when we do the mobile brigades, we have to be very careful to make sure that we provide services to the Venezuelans, but also to the citizens, to the Colombian citizens, because if not, you can create very unsafe environment even for our workers. So it's getting a little out of control, and it's this balance that you have to create when you develop programs which focus is migrant population. You can never forget the actual the population that is already living in those places, and you need to make sure that in some way you include them, not only the professional services, but also in the advocacy actions, and also in terms of educational workshops and meetings, because if not, you create very unsafe environment for everyone who has to move around and helping them.
Thank you, Marta. And again, folks, you can add questions or comments in the question box or chat box. Patrick, did you have any further information on that question?
Okay. In South Sudan, generally, abortion is a taboo. People don't talk about it now. Now, like 6 years ago, that is for this community in the POC, they had not talked about abortion. They don't want even to talk about abortion. But now their situation in the POC has now forced them to face the reality. Previously, for example, if a girl accidentally got pregnant, the parents of the girl would make sure the girl marries that man who is responsible for that pregnancy, and there's no like issue of terminating this abortion and so on, and they make sure they arranged proper marriage. But now with the current situation of the war, parents could now see this, okay, we can now terminate this child because we want this girl, to bring dowry for the family and so on. So that is basically how the situation has changed because of the current conflict.
Okay, thanks for that. Patty, there's a couple of comments really in the question box that I'll read to you. One, thank you very much for this presentation. There is such a huge need to discuss around legal risks connected to abortion, not only organizational, but individual too. Looking forward to seeing the tool released soon. And then another comment, it's the way forward, in my opinion, too many times than none. We are working in not illegal environments, but risky anyhow. Studying the legal framework with a risk assessment is the way to understand what operational way can be taken by the NGO partner. And if you want to reflect on that, feel free to. And then there's another comment, Marta, that says the situation in Colombia sounds very similar to that of Lebanon, with xenophobia towards Syrian, Iraqi, and Sudanese refugees. Have you also found that UNHCR relies on abortion services, even in places where it's legally restricted, almost as a prerequisite for asylum and resettlement to be granted? And Patrick, one more question for you. What is the reason for low use of contraceptives in Sudan? So I'll turn the floor over to Patty if you want to reflect first, then Marta, and then Patrick.
Sure. Yeah. Thanks for those comments, and it's nice to hear that it's useful, especially when we're not traveling. You kind of feel like you're doing your work in your little bubble, so it's of your office or wherever. So so I appreciate that comment. And just to note, I mean, abortion laws are very complicated when it comes to healthcare law, and most of them come with criminal sanctions. Even here in the U.S., where abortion is legal, we see arrest, and so I do just sort of to reemphasize that it's important to really understand the context in terms of risk rather than the simple legality. These days doesn't really cut it when we're looking at abortion services. It's really more about understanding the overall context, not only the way that judges and lawyers would look at abortion, but also the way that police and peacekeepers and the whole entire environment, the whole attitudes and actions of the entire context vis-a-vis the abortion law. So thanks for those comments. I'll turn it over to Marta.
Such a good question, and you know what? I think that like all of us that sharing this meeting, for us it's normal to talk about abortion. For us it's normal to study, to understand it, to carry out research and to carry out advocacy actions and to bring the subject into the meetings. But even in meetings where you know that that it is that the people and all the agencies understand it, it is not an easy thing to introduce. Even in a legal context like the one that we have in Colombia, because at the end you still see the same stigma, even in officials that are supposed to make sure that, you know, that the services is provided, even in some agencies that that have been supporting safe and quality safe abortions. So even in that space of confidence, it's really hard to insist and to bring the subject. And what we have seen is that many times, you know, they put it in writing. You know, we have to make sure that this program is carried out and that safe abortion is included. But when it comes to make it a reality, everything gets lost in the way. So at the end, there are very few organizations like Pro Familia, very few, that even in a context of legality and rights, end up providing the services for the population, for the Colombian population. Now imagine for migrants, that's even harder to do. So I think that I know that is a work that we have to keep on doing, but it should start at the top. If you have all these agencies and it is part of their mission to make sure that happens, especially when you have all the laws, we have to work more towards guaranteeing that becomes a reality. Because if not, what you end up having is, I mean, right now the percentage of unwanted pregnancies, like 70% of unwanted pregnancies, and then you end up with the health system saying, oh, there's too many women having children. Well, you know, you have the law, you have you should provide when they want to. You should make sure that they have access to an abortion if they decide to do so. So it's very contradictory, but we have to keep on doing, you know, insisting. And in that point, what Patty suggests, I'm trying to think, I have to analyze a little bit more if that can really make a change in the stigma and the actual provision of the services. But it's an interesting point of view, trying to see it differently, you know, and see if that works.
Thank you. And Patrick, that question about contraception.
Yeah, actually, there are several reasons why contraceptive prevalence rate is low in South Sudan. One of the top reasons is that the lack of information, the misconception among the community. People still believe that, oh, this war that started in 1983 has killed so many people, so we need to, you know, fill in those who died. So people don't want to talk about family planning any of these contraceptive. And even the providers, they are limited with the challenges we have. Most of the health facility in rural area do not have access to these services. And the providers, sometimes even in the cities, like in Juba, sometimes they get threatened by the partners when they get to learn that their wives were, you know, provided with any of the contraceptive method. So this has generally affected the uptake, the usage of contraceptive in South Sudan. So those are the reasons why we have a low prevalence rate.
Okay, thank you, Patrick. Let me just read one final comment in the comment box, and it's about the legal risk tool. It says, in my opinion, this tool should be done beforehand to any SRHR project start, whatever the context, humanitarian or development. Should be done in collaboration with the coordination and field teams. Also, in the risk list, it is important not to forget that the risk often can also come from inside agencies and NGOs, which are supposed to be allies, like camp management agencies like UNHCR, ... Okay, I think with that, we need to call this to a close. Our time is at end. Let me call your attention to the link in the chat box where there is a Google little Google survey form you can link to and add some feedback about the legal risk tool that we would appreciate very much. And let me just thank all presenters, Marta, Patrick, and Patty, for this great work, for the fascinating presentations, and your patience with us as we work through all the technical troubles, and thanks to all the attendees as well. We appreciate your attendance, and we'll try to make slides and links for recordings available so you can see everything, even the pause while we worked on the technical problems. Appreciate your attendance, and everyone have a great day.